We present an arthroscopic technique for chronic acromioclavicular joint dislocations that involves reconstructing the acromioclavicular and coracoclavicular ligaments using an autogenous gracilis tendon graft reinforced with fiber tape. The patient was positioned in a beach chair position with arm draped separately and kept moving freely without a traction device. The ipsilateral knee was prepped and draped for tendon graft harvesting. The prepared tendon is augmented with a fiber tape internal brace. A dog button is placed in the middle of the prepared graft over the fiber tape, making the tendon graft double-stranded. Using a 4 mm 30-degree arthroscope and standard posterior soft tissue portal, a diagnostic glenohumeral arthroscopy is done. The rotator interval is exposed using a radiofrequency probe. The undersurface of the coracoid is exposed and skeletonized of the soft tissue attachments, using midaxillary portal as visualization portal. The pectoralis minor tendon is exposed and released from the medial side of the coracoid working from the trans pectoralis major portal, made medial to the conjoint tendon. Further, coracoid is debrided of all soft tissue except for conjoint tendon attachment. Visualizing from the midaxillary portal, the supracoracoid portal is made and drilling sleeve is passed aimed for the knee of the coracoid. The coracoid tunnel is made with calibrated guide wire and sequential reaming is done for matching the graft diameter, which is kept less than 6 mm. The nitinol wire loop is passed through the coracoid tunnel and parked outside the anterolateral portal. The nitinol wire loop is replaced with number 2 PDS suture loop. The acromioclavicular joint is exposed using a minimal incision and distal end of the clavicle measuring 10 mm is resected using the bone saw. 2 tunnels are drilled from the posterior to anterior direction over the superior surface of the clavicle approximately 25 mm and 45 mm from the distal end of the clavicle with cannulated 3.2 mm drill bites over pre-drilled K wires. An 18-gauge wide-bore needle was used to shuttle a non-absorbable PDS suture through the clavicular drill holes. The PDS suture ends are visualized from mid-axillary portal and retrieved outside the anterolateral portal. The fiber tape ends are shuttled through the nitinol loop and retrieved through the coracoid portal. The ends of the fiber tape are pulled through the clavicular tunnels till the dog button was seated well under the coracoid surface. The distal end of the clavicle is reduced with a bone spike placed on acromion under surface as fulcrum under fluoroscopy for anatomical reduction of the joint. The remaining tendon ends are passed through the tunnel in the acromion, which was drilled with a cannulated 3.2 mm drill bit in the posterior to anterior direction. The tendon ends are secured together in the figure of 8 configuration reconstructing the acromioclavicular ligament. This provided both horizontal and vertical stability to the anatomically reduced AC joint. The final arthroscopic evaluation is done from the mid-axillary portal and the dog button seated flush over the coracoid undersurface with the gracilis graft is visualized. The 2 limbs of the graft recreating the double bundle coracoclavicular ligament are visualized to have adequate tension. The final fluoroscopic evaluation showed well-reduced AC joint. The superior capsule is approximated over the AC joint and the wound over the AC joint is closed in layers.